A very good afternoon to everyone. I thank Sposi, Dr. Shukla, Dr. Pandey, and AIOS for asking me to be a part of this symposium. I would be talking on decoding anomalous head posture. Now, if you, when you see this child with such head posture, you automatically start thinking what the child has. So there are so many components to the head posture in this child. There is a tilting of the head, there is elevation of the chin, and so many components. So as you make the child move, in this case, it is clear that he has a left bounce, and because of that, he has adopted that head posture in order to correct the deviation. So, cracking a head posture, we need to think on our thinking cap. So, how do we maintain the normal head posture? It is due to inputs from otolith apparatus, semicircular canals in the labyrinth, proprioceptives in the neck muscle. Inputs travel to the vestibular brain system, brainstem nuclei, to vestibular cortex, to cervical cord and the neck muscles. There are also direct pathways from labyrinth to extraocular muscles. Ocular torticollis occurs due to disturbance in input from afferent visual pathways, oculomotor nerves, and vestibular apparatus. Now, what are the types of head posture? Head postures are, there is a face turn or to the right or left, which occurs along the vertical axis. If there is along the horizontal axis, we have a chin up and chin down head posture, and along the antero-posterior axis, we have tilting of the head to the right or left shoulder. Now, various types classified, like this is a congenital type of head posture, which is seen in the congenital fourth nerve palsy. You can see the marked facial asymmetry, and this is the acquired one. There is a face turn in the left sixth nerve palsy. It could be also according to the timing, which is paroxysmal head posture, as in a case of fusion maldevelopment nystagmus, or as you can see in this child, it is changing head posture in a case of periodic alternating nystagmus. So, in cases of nystagmus, you always have to observe the child for about 3 to 4 minutes before deciding on what type of head posture he has. Then it could be persistent, as in left, this case of superior oblique head posture, he has a chin down head posture. There are certain non-ocular causes which would be because of congenital contracture of sternocleidomastoid, or acquired causes, as in acquired or non-trauma, non-traumatic, so many causes. How do we differentiate the ocular from non-ocular torticollis? In ocular torticollis, the head tilt is to the opposite side, as in case of congenital superior oblique, whereas because the contracture of sternocleidomastoid, the head tilt will be on the same side. The ocular deviation increases on correcting the corrective head posture in ocular torticollis, whereas there is no effect on ocular deviation. On palpating the lid, we don't notice any abnormality, whereas we see a cord-like muscular structure in contracture of sternocleidomastoid. The compensatory head posture is to optimize the visual acuity, as in infantile nystagmus, ptosis, significant refractive error, restrictive strabismus, or infantile ESO with cross fixation. So these are the head postures in various infantile nystagmus or bilateral ptosis. Compensatory head posture is also for maintaining binocularity. As you can see in this girl, she had a head posture because of Duane's retraction syndrome, which is corrected after correcting her deviation. Now, this lady had a head posture again, but She had neither glaucoma, neither strabismus or nystagmus. She had advanced visual fields and tubular fields, and so she adopted this head posture so that she could see better. Then when coming to the examination, we have to see for certain physical features like patient's features of facial asymmetry, to know the characteristic of anomaly. Always review the old photos, that is the FAT scan, which will tell you the duration of the deviation. Occlusion of one eye always abolishes the head posture if it is ocular torticollis. Eye movements detects concomitant strabismus or nystagmus. Measuring the head posture with a goniometer helps in deciding the management. Visual fields in absence of strabismus or nystagmus, refraction, fundoscopy, and palpation of neck muscles. So coming to the management, now this is a congenital fourth nerve palsy. I've shown you the preoperative images, and there was a esotropia along with hypertropia. Hypertropia was asymmetric more in right eye than in left eye. There was excyclotorsion, and this case we managed by doing recess resect procedure in the right eye, the inferior oblique recession with superior oblique tuck in the right eye, and inferior oblique recession in the left eye, which corrected the horizontal deviation, reduced the V. However, the facial asymmetry remains. Now, this was the preoperative head posture, which was corrected postoperatively. Now, this was an interesting case of acquired superior oblique palsy. He had a minimal L by R, which increases in the dextrodepression. And the Hess chart also showed an overaction of right inferior rectus muscle maximally. So we just did a recession of right inferior, contralateral inferior rectus, which corrected the head posture, and his diplopia also corrected the anomaly on the Hess chart. So this was his pre-op head posture, chin down, which was corrected. Now, this was a 41-year-old female who had a double vision since 7 or 8 days. There was a history of fever. She had a face turn to the left and left esotropia on correction of head posture. Esotropia was very less and abduction deficit was grade 1. So, she had a subtle left lateral rectus paralysis. So, we gave 4 units of Botox to left medial rectus under local anesthesia. We gave 5 millimeter away from the insertion of the muscle along with oral steroids. So, post-operatively or post-Botox, her deviation reduced, her head posture reduced, and diplopia also reduced, and she didn't have further recurrence. So this was a pre-op head posture, and this is the post-Botox head posture. Now this was a case of 6 nerve palsy. She had a history of trauma and had a bilateral 6 nerve asymmetric. Right side was more and left was less, and she had a significant head posture because of the large angled esotropia she had. So we subjected her to bimedial recession with modified Nishidas to the right eye, and left eye medial rectus we had kept on adjustable suture. So this corrected her primary position deviation. Her head posture was significantly corrected, though some abduction deficit remained. Now this is a case of fusion development, fusion maldevelopment nystagmus, who had a significant head posture preoperatively with a large angle exotropia with aexotropia. So he underwent in the right eye LR recession with SR recession with PTSO, and left eye we did an LR recession of 12 mm. We adjusted the dosage. MR plication of 8 millimeters, SR recession of 5 millimeters, and PTSO. So that corrected his head posture as well as his exodeviation significantly. So take home points are assess the head posture properly, learn the Park's 3-step well. In nystagmus cases, observe the child for 3 to 4 minutes before deciding on the head posture. Old photos give an invaluable clue. Thanks for your patient listening.
Thank you, Shubhangi, for very interesting talk. Of course, head posture can be either, it could be diverse etiology from congenital to acquired, and the acquired ones are more troublesome because they end up with diplopia. So each one has to be tackled accordingly, and you have covered in great detail. One more thing which can cause abnormal head posture, like astigmatism also at times can give rise to, so even if it is in, yeah, that is also, so, yeah, doctor, you want to say something?
DVD as a cause of head posture because the management will be different in DVD compared to other head postures. Because in DVD, the head posture is towards the fixing eye. Supposing there is DVD bilaterally, right eye more than the left eye will be the fixing eye, that will tilt the head to the left side, not to the right side. One of the reasons why this happens is because there is an inferior oblique overaction in DVD, and to reduce the inferior oblique overaction and cause exotropia, you have to tilt the head to the other side. If you tilt the head to the right side, there will be intorsion of the right eye and extorsion of the left eye.
Yeah.
And that's the reason why in DVD you get head posture towards the other side.
There's one more, okay, finish it.
Okay, so it's important to differentiate between superior oblique palsy, where the head posture is towards the opposite side, and DVD, where it is towards the same side.
No, but that is only in case of whether the inferior oblique palsy is then only, no? Or overaction.
No,
You mean?
what I'm saying
DVD, not every DVD has inferior oblique anomalies.
I said 35% to 50% of the DVD have head posture. Not everyone has head posture.
Yeah, that's important point. Only thing is DVD can have many reasons for abnormal head posture.
Yes.
One important reason is latent nystagmus also.
Yes.
So that has to be evaluated. That's quite often that is the reason. So
No, whenever there is a head tilt, you think of DVD also as a cause of head posture.
Yes, at times you can also superior oblique palsy and DVD, so that creates a lot of diagnostic issues. That's true.